Chris Rapoff of DC QME Continuing Education, and welcome to this week's presentation. Today, I'd like to discuss a rather uncommon neurological disorder that's characterized by a rapid onset of severe pain in the shoulder and the arm, primarily involving the brachial plexus. This is known as Parsonage-Turner syndrome, or PTS. Now, the exact cause of PTS is unknown, but it's thought to be caused by an immune-mediated disorder. The severity of the disorder can widely vary from one individual to another, due in part to the specific nerves that are involved. Now, the affected individuals may recover without treatment, meaning that their strength would return in their affected muscles and the pain goes away. However, there are some individuals that may experience recurrent episodes, and some affected individuals may experience residual pain and potentially significant disability. Today, I'm going to provide you with some clinical insights and clinical characteristics that are really necessary for you to have a firm grasp of before finalizing a diagnosis of Parsonage-Turner syndrome in an examinee. So let's get started. First, these are the following sources that I referenced when producing the presentation of Parsonage-Turner syndrome. I encourage you to explore these references if you would like a more in-depth understanding of our discussion today. Parsonage-Turner syndrome was first described in medical literature in the late 1800s, and it was extensively documented by Drs. Parsonage and Turner in 1948, and they named it amyotrophic neuralgia. Now, there is also an extremely rare inherited form known as hereditary neuralgic amyotrophy, in which the National Organization for Rare Diseases, also known as NORD, has a separate report. Now, PTS is sometimes referred to as idiopathic neuralgic amyotrophy to distinguish it from the genetic form and to highlight its unknown cause. Now, PTS is typically classified as a peripheral neuropathy as it affects the peripheral nervous system. There are some very common synonyms for PTS that I'm sure you're all aware of. They include acute brachial neuritis, or just brachial neuritis, brachial plexus neuritis, brachial plexus neuropathy, idiopathic brachial plexus neuropathy, neurologic amyotrophy, and PTS. So some characteristics of this syndrome, or some key symptoms, would be an abrupt onset of pain in one shoulder, rarely affecting both shoulders. Pain is actually described as a sharp, aching, burning, or stabbing pain that may extend to the neck, the arm, the hand, on the ipsilateral side. Now, the phases of pain, well, the acute phase, the pain is continuous, very severe, and often worse at night. The chronic phase, you would have a persistent low-grade pain that could actually last a year or longer. There's muscle weakness and atrophy. That occurs days to weeks after the initial onset. It ranges from mild weakness to a near complete paralysis, and muscle atrophy will progress over time. Big characteristic of this syndrome. Additional symptoms can include sensory deficits such as hyposthesia, numbness, or tingling or prickling sensation, paresthesia, or painful sensation due to light touch, dysesthesia. And finally, there can be reduced or absent reflexes in the affected area. Some additional characteristics include the complications. There are shoulder and arm deformities that are basically due to the muscle atrophy. These could be, for example, impingement syndrome or subluxation. There are also contractures, such as adhesive capsulitis, that would cause pain and reduce joint motion of the shoulder. There's additionally involvement of other nerves potentially. The lumbosacral plexus can have pain and sensory changes in the legs. The phrenic nerve can produce shortness of breath. And recurrent laryngeal nerve involvement could cause vocal cord weakness, hoarseness, or soft speech known as hypophonia. Now, the impact on the skin and the blood vessels, well, there would be changes in skin color, swelling, and abnormal hair or nail growth potentially. Now, there can be also impaired temperature regulation and excessive sweating. Now, if you notice these symptoms, these are very similar to symptoms of CRPS as well. So these are things to take into consideration when you're providing a differential diagnosis. Looking at a prognosis here, approximately 70 to 90% regain the strength and functionality within 2 years. Now, 2 years is a pretty long time for this type of pain. And some experience residual pain with impaired movement or potentially significant disability. The exact cause of Parsonage-Turner syndrome is really unknown, though immunological, environmental, and genetic factors are actually believed to contribute. Now, most cases are thought to result from an immune-mediated inflammatory response that would be triggered by infections or environmental factors, with viral illnesses being the most common trigger. Additional triggers include immunizations, surgery on the brachial plexus, strenuous exercise, minor trauma, bacterial or parasitic infections, anesthesia, and autoimmune disorders like lupus or temporal arteritis. In some cases, childbirth may also act as a trigger in females. So while there is no specific causes identified in some individuals, the researchers suggest that there could be a genetic predisposition that takes certain people that are more susceptible to develop PTS when they're exposed to these triggers that I just mentioned. And these specific gene variants may only activate under those certain circumstances. Who is affected this condition? Well, Parsonage-Turner syndrome is more common in males than females, with an estimated incidence of only 1.64 to 3 cases per 100,000 individuals annually. However, the actual frequency may be higher due to an underdiagnosis or a misdiagnosis, as you saw that many of these conditions can actually mirror other conditions that are very common. And PTS is also primarily affects the young to middle-aged adults, but is actually has been observed in children and in the elderly. Now, as I mentioned, some overlap of symptoms for other different types of syndromes and diseases, let's take a look at some disorders with the similar symptoms. Several of these conditions may present similar to PTS, and they include bursitis, rotator cuff injuries, calcific tendonitis, impingement syndromes, Guillain-Barré syndrome, cervical disc disease with radiculopathy, mononeuritis monoplex, and other potential mimics could be amyotrophic lateral sclerosis or Lou Gehrig's disease, chronic inflammatory demyelinating polyneuropathies, polymyalgia rheumatica, thoracic outlet syndrome, and a brachial plexus injury related to potentially cancer like a neoplastic brachial plexopathy. Additionally, this is interesting, adhesive capsulitis or the frozen shoulder can occur as a complication of PTS, but it also can arise independently. All right, let's see how we diagnose this condition. Well, it actually involves identifying some really characteristic symptoms and reviewing a detailed patient history and conducting a thorough clinical evaluation that is supported by tests. They say that the key diagnostic tools include a nerve conduction study, which would assess the ability of the peripheral nerves to transmit the impulses to the brain, and electromyography, which would evaluate the muscle responses to the nerve signals using a needle electrode. And these tests also help to pinpoint nerve damage and the origin of the damage. MRI is another essential diagnostic tool as it excludes other causes of shoulder pain. It could also detect muscle atrophy and highlights nerve-related changes. Also, traditional x-rays can be used to rule out other shoulder conditions that could contribute to the symptoms that we described earlier. So as far as some standard treatment options, no surprise that there's no specific treatment for Parsonage-Turner syndrome. And the management is tailored pretty much to the individual symptoms, often requiring a team of specialists. Now, in some cases, PTS resolves without treatment, and it relies basically on supportive measures like pain management with opiates and NSAIDs. Corticosteroids, such as prednisone, can help reduce the pain and speed the recovery during the acute phase, but the effectiveness of those is pretty inconsistent in the records. Now, nerve-specific pain medications like gabapentin, carbamazepine, and amitriptyline are often prescribed in the acute phase. The physical and the rehabilitation therapy include active and passive ranges of motion, help preserve muscle strength and prevent contractures, although muscle strengthening is typically avoided during the acute phase just due to the pain processes themselves. Now, other techniques like heat, cold application, and the TENS unit may help alleviate some of the pain or at least make it more bearable. Additional therapy options include a surgery, which could be a nerve grafting or a tendon transfer. And that might be considered if conservative treatments fail. And the grafting is most effective within 6 to 12 months, and the tendon transfers after 2 years. Now, the prognosis actually will vary as well. As I mentioned earlier, many regain 70 to 90% of their original strength within 2 years, but some can experience residual pain, reduced mobility, or significant disability. With 5 to 26% suffer the risk of recurrence and potential long-term complications, such as a winged scapula. So I hope you found the discussion on PTS informative for you and in this rare neurological disorder. But in summary, the Parsonage-Turner syndrome is a neurologically rare condition that's marked by the sudden onset of severe shoulder and arm pain, and it can last from hours to weeks. Now, as I mentioned, the acute phase is typically followed by a muscle weakness and atrophy in the affected area, and the disorder primarily impacts the brachial plexus and the sensation of the shoulders, arms, hands, although other nerves in the arm and the leg can be involved, as I mentioned, the lumbosacral nerves. Now, while the exact cause of this condition is unknown, it is believed to be the result of an immune-mediated disorder, and the symptoms and the severity basically vary among individuals, although the recovery may occur without treatment, but some people may experience recurrent episodes, residual pain, or significant disability. So, doctors, in conclusion, I just wanted to thank you for taking the time to join me in this presentation today. I hope you enjoyed it and learned some information, some new information on a pretty rare neurological condition, PTS. I hope you enjoyed it, and I do look forward to sharing some other interesting subjects as they relate to the workers' compensation system in the state of California. And until next time, thank you.